Hello, everyone. This is Qasim Aziz. I'm a professor of neurogastroenterology at the Wingate Institute in London. And I'm going to talk to you about managing gastrointestinal complications in EDS. And in this presentation, I'm going to try and focus on some of the uncommon complications and also in some of the less common forms of EDS like vascular EDS and ACNES, etc. So just going to start with a description of what symptoms, gastrointestinal symptoms patients with HEDS and HSD largely present with. But suffice to say that any subtype of EDS can present with very similar symptoms. So if you look at the list over there, you can see that some of the most common symptoms include nausea, which can occur in anywhere between a third to two-thirds of patients, and similarly heartburn is incredibly common. Bloating is even more common, and more than half of the patients suffer from bloating. And another very common symptom is dyspepsia, which is also described as indigestion. And there are two types of indigestion, one which is associated with upper tummy pain, and the other one is associated with fullness after a meal. And as you will see, they are both very common indeed. And in our clinics, this is perhaps one of the most common presentations alongside with the lower bowel symptoms, abdominal pain, as you'll see, between 56 to 100% of the patients in different series have complained of abdominal pain. And problems with bowels like constipation, diarrhea are also not so uncommon. But alternating bowel habits, which basically means that patients can have constipation for a while, then can have diarrhea for a few days, and then they go back to experiencing constipation, is again a common symptom that we see in our patients with EDS. Now, this is the presentation, but what are the complications that we see in our patients? And I've divided that under a number of different headings. The first one relates to altered anatomy, where the structure of the organs in the gut is in some way abnormal, and that can lead to a whole range of symptoms, and we'll go through that in my talk in shortly. I'm going to talk about a condition that sometimes can be quite difficult to treat called overflow diarrhea. And this can be quite misleading because the problem there is actually not diarrhea, it's constipation. And we'll talk about that. A condition that I see quite a lot is abdominal wall pain. And this is a type of pain which is often misdiagnosed as coming from the organs, whereas it's actually coming from the nerves and muscles of the tummy wall. We're all familiar with mast cell activation syndrome, and we certainly see manifestations of that in the gut, so I will touch upon that. A condition called Eosinophilic Esophagitis we see a fair amount of as well in our EDS patients, particularly those prone to allergies, and this is basically an allergic manifestation of certain allergy cells that come into the esophagus, and there they can produce symptoms. Then we see a small subgroup of patients with vascular entrapment syndromes, with one blood vessel in the tummy is causing pressure on another adjacent blood vessel, and that produces symptoms. We see intestinal perforation, vascular aneurysm, and bleeding disorders, mostly in vascular EDS. I'm going to talk a little bit specifically about ACNES and vascular EDS. And finally, I'm going to touch on POTS because I know this is a common problem and we are learning more and more about how POTS affects the gastrointestinal tract. So let's start with the hernias. Now, there can be many different types of hernias that can be present in the abdomen. There can be those that are really related to the abdominal wall. So there are a number of weak points within the abdominal wall, and that is through these weak points in the intestine can bulge out through the muscle. So if you see on the right-hand side of the screen, there is this cartoon which shows this layer of abdominal wall muscle, and then there is the intestine, and the intestine is herniated through the weakness in the muscle wall and gone beyond the muscle and is pushing the skin outwards. So you can see a bulge there, and you can see that there is a loop of intestine which has come through this weakness in the muscle. And sometimes, quite often, there is a bit of fat that is present there as well, which is the fat just underneath the skin. And you have a layer of the peritoneum, which is a covering around the intestine, which comes along with the loop of bowel that has come through. Now, on most of the occasions, this loop that has come through can be pushed back with gentle pressure. So if you just put a bit of gentle pressure on your tummy wall, you can push this loop back. And it tends to come out whenever there is increase in abdominal pressure, like when you cough, when you sneeze, when you've been up and about for a long time. This piece of bowel can herniate out, and you can then put it back by a bit of gentle pressure. But sometimes it can get stuck there, we call an obstructed hernia, and that can become quite painful because the bowel hair, the blood supply to the bowel can be compromised, and that can cause quite severe pain. Now, there are many different parts of the tummy wall where this can occur. This can occur right in the middle here where the belly button is, called the umbilical hernia. If you've had previous operations, for instance, of gallbladder has been taken out, just where the scar is, because the muscle layer has been cut through during surgery, you can actually get a loop of bowel coming through over there. And similarly, you can get a hernia in the upper part of the tummy just below the breastbone, which is described as an epigastric hernia. And then there are these inguinal hernias and femoral hernias more in the pelvis and in the groin area. And what is generally known is that patients with EDS are more prone to these hernias, and they're more common, particularly so in the more classical type of EDS, vascular type of EDS. But we see that in hypermobile subtype as well, in HSD as well. But we also see another type of hernia, which is an internal hernia, often described as a hiatus hernia. So what a hiatus hernia means is that the small part of the stomach has herniated through the diaphragm into the tummy cavity, into the chest cavity. So here what we see is the esophagus, or the food pipe. And as it comes, this is present mainly in the chest, and it comes down and it goes through a hole in the diaphragm, which is also called the hiatus, is entirely within the tummy cavity, and the esophagus is in the chest cavity, and the two cavities are separated by the diaphragm, and there is a hole in the diaphragm through which the esophagus comes down and meets the stomach. In a hiatus hernia, because this hole becomes a bit wider, a bit more lax, the stomach herniates upwards into the chest cavity, and that is what a hiatus hernia is. And the problem with hiatus hernia is that it compromises the valve at the lower end of the esophagus, which prevents acid from going up from the stomach into the small bowel. So patients with hiatus hernia can experience more acid reflux, they can get more regurgitation. Very occasionally, this hiatus hernia can be very big, and that can start to cause pooling of food and debris in this hiatus hernia, which can then cause difficulty with swallowing and quite a lot of reflux that can occur of food that is sticking in the hiatus hernia that can come back up into the upper part of the esophagus, or even sometimes can come all the way into the mouth. And very occasionally, this hernia can also get stuck and the blood supply can be compromised, but that's a very uncommon occurrence. Now, moving on to another type of anatomical problems that we sometimes see, which is described as visceroptosis. What we mean by visceroptosis is that the organs are hanging very low in the tummy cavity. Now, this is a picture, an X-ray, barium X-ray of the stomach. And what you can see, the pelvic bones are over here, that you can see just where the arrow is, and the stomach is hanging so low down that it's actually in the pelvis. And this is visceroptosis of the stomach. And here you see, this is again another barium X-ray, which shows that the entire small bowel, this is the small bowel, is actually sitting in the pelvis. It should be above the pelvis, but is actually in the pelvis. And this is in the section C of this slide, you can see that this is the transverse colon, which is the part of the bowel which is in the middle. It's usually just under the diaphragm, and this is also hanging in the pelvis. And similarly here, the entire colon has come down, and it is most of it is in the pelvis. So the sort of symptoms that you get when your organs are lying very low, and that's largely because the mesentery, which is where all the blood vessels and the nerves, etc., that supply the organs, is very loose and lax, and that has actually allowed the organs to come down, and it produces a dragging sensation. And patients present in many different ways. They can present with this dragging sensation, they can present with pain in the tummy, they present with bloating, and particularly with pelvic bloating, because when they stand up, they suddenly describe that. They suddenly notice that the lower abdomen and the pelvis starts bulging outwards when they stand up. And there is some recent data which suggests that there is a compromise on the blood flow during change of posture. So as some people stand up with significant visceroptosis, and there is a pressure on the mesentery which carries the blood vessels, that can lead to a reduction in blood flow in some of the bigger blood vessels of the tummy cavities, such as the superior mesenteric artery, which is one of the common arteries that supplies blood to the upper part of the gut, and there is some suggestion that blood flow there can be decreased, and that can also produce pain and discomfort. Now, the treatment for all of these types of hernias as well as visceroptosis can be surgery. The abdominal hernias that I showed you before can be treated surgically. The hiatus hernia can be treated surgically. And visceroptosis, if it happens to one organ, that can be stitched up. But there is very little data as to what the outcomes of surgery are, and they're only just... And most surgeons are, because of lack of experience, and secondly, also not knowing what the outcomes will be, because it is possible that this may recur. But thankfully, it happens very uncommonly. And in most of the patients that we see, the symptoms are really very mild. And with just a bit of reassurance and symptomatic management, we can usually help them to overcome their symptoms. Now, excuse me. Constipation is a common problem in our patients with Ehlers-Danlos syndrome. And what you see in this X-ray is that the subject has taken some radio-opaque markers. So it has swallowed some capsules which are visible on an X-ray. And this X-ray has been taken 5 days later. And you see that most of these radio-opaque capsules that the patient swallowed are still lying in the bowels. This suggests that transit or movement within the bowel is very sluggish, something that we call slow transit constipation. But we also see another problem, which is a rectal evacuatory dysfunction. And in rectal evacuatory dysfunction, we see some anatomical. On the left side of the picture is normal anatomy of the pelvic organs. You have the rectum, which meets the sigmoid colon just above, so it's like an S-shaped structure, and then it opens into the anal canal. You have the uterus and vagina in front, and patients with EDS tend to get a higher incidence of developing anatomical problems like rectocele. Rectocele is a pouch that forms in the rectum, and it can put pressure on the vaginal wall. And the problem that it produces is that it can trap stool within this pouch. As the stool passes across this pouch, some can fall into the pouch, and that can give a feeling of incomplete emptying after a bowel movement. And similarly, sometimes you can get a prolapse, an internal prolapse of the rectum falling onto itself like a concertina effect, and that can also produce a blockage-like feeling. This can be treated through a range of therapies. You can try and strengthen the pelvic floor so that there is less straining, so there is less bulge, less collapse, and there are very good specialist pelvic floor therapists who work specifically on it and use techniques such as biofeedback, etc. But sometimes if the prolapse is quite large, or this pouch, the rectocele is very large, and is causing quite a lot of problems to the patients, then these can be treated surgically as well. Now, I mentioned overflow diarrhea before, and I'd just like to explain that again. You can take this analogy of a waterfall, that usually on top of a mountain you have a big sheet of ice, and around the ice there is water flowing, because as the ice melts, the water comes down as a waterfall. And the same thing can happen in patients with severe constipation, that there's so much compacted stool in the bowel that it hardly is not able to move very well. And eventually a stage comes that bits of it start to break on the edges. And this liquid stool that breaks on the edges then comes down all the way into the rectum. And that often produces a very sudden sensation. So there is an urgency that you may have been constipated for weeks on end, and suddenly you get an urgency, oh, I need to go, because suddenly a lot of this fecal and water fluid has dropped into your rectum, and you need to run, and it is diarrhea. And this diarrhea can continue for a day or so, and sometimes for longer as well, giving the false impression that this is actually, there is another cause of diarrhea. And people start to take medicines to stop the diarrhea, such as Imodium and so on. And that actually makes the problem worse and makes the constipation worse. And then eventually there will be more overflow. So the treatment, if you actually take a simple X-ray, you can actually see the impacted stool in the bowel. And the treatment is actually to flush the stool out. And we tend to use medicines that are used for preparing people for colonoscopies, described as bowel prep, or very other strong laxatives to try and shift this hard stool and help our patients. It's not until you've shifted all the stool that the diarrhea will stop sometimes. Another condition that I see quite a lot in my practice is abdominal wall pain. And by what we mean is that there are a number of structures just underneath the skin. Predominantly, these are muscles and nerves, which can cause pain, just like muscles and nerves can cause pain anywhere else in the body. And as you can see in this picture, you can see all the different type of muscles and nerves over them. And the muscle that is particularly important is in the middle, called the rectus muscle, and it extends for about 5 or 6 centimeters on either side, all the way from the rib cage down into the pelvis. So this is the muscle that people go to the gym and work out and try and get a six-pack. And what you also see is that going through the muscle, these white sort of cords that you see here are little nerves that can go through the muscle. And there are about 6 of them all the way from just underneath the rib cage to the pelvis. And these are called anterior cutaneous nerves. Now, these nerves, as you can see, they're coming through the muscle, and they come through a canal in the muscle. So what you see is this white cord that is going through a little bit of anchoring tissue here, and then goes through a canal in the muscle. It's a fibrous canal. And in this canal, there is an artery as well. Then it goes through the muscle and then turns at right angle and supplies the upper layer of the muscle and the overlying skin. And what can happen is that this nerve can get trapped in this canal through repetitive strain over the tummy muscle. So we see it sometimes in athletes. I've seen it in jockeys, that because of the strain that they get on the abdominal wall muscles, because of the position that they sit in, there is a recurrent trauma to this region, and you can actually get a trapped nerve. We see it after pregnancy, We see it after surgery. People who've had surgery for their gallbladder or appendix, etc., they can develop some scar tissue there, which can cause entrapment of this nerve. We sometimes see it with blunt trauma. And quite often in our EDS patients, there is no other underlying reason for it, except that we think that the core strength in our EDS patients of the back muscles is poor, and therefore they overuse their abdominal muscles to stabilize, and that causes this entrapment of nerve. And we've recently done a study in our department which shows that this is a common finding in our ED. About a third of patients that present to us with EDS and abdominal pain can have this nerve entrapment type of pain. One characteristic of this pain is that it's present 24/7. It's always there, and it's worse with exertion, with exercise, with movement, even turning sides in bed can be painful, bending down can be painful, etc. And it's very localized, usually quite sharp and localized to specific areas. And you can have multiple nerves, as you can see over here, that can be trapped. So that can be confusing because the pain can be spread over quite a wide area. Treatment of this is conservative measures. We usually ask patients to do deep tissue massage over these trigger points where they feel the pain, apply a bit of heat with a heat pad, and sometimes apply some non-steroidal gel if you're not allergic to it, like ibuprofen, Voltron, etc. And take simple painkillers like paracetamol. However, and do some exercise to strengthen your core strength. However, if that doesn't help, physiotherapy can be very helpful. And we have an excellent physiotherapist, Anne McCarthy, who has helped so many of my patients by doing trigger point release as well as improving their core strength, etc. But if all of those measures don't work, then we send our patients for trigger point injections with local anesthetic and steroid, or local anesthetic and Botox sometimes. And some patients find that very helpful, but it can recur after injections. Some people get relief for a few weeks, others for a few months. Some never come back after their injections, others come back because of the pain has recurred. And in those who keep getting recurrent pain despite adequate treatment, neurectomy, which is that the nerve itself can be cut in the canal, or the canal can be opened up to surgery, can be tried, but there are very few surgical specialists who would take that on. There's certainly in Europe, there's a center in Eindhoven in Holland where they specialize in this type of surgery. Moving on to mast cell activation disorder, I'm sure other colleagues will cover this subject in more detail. Suffice to say that the release of histamine from the mast cells has an effect on the gastrointestinal tract as well. And these are patients that we see who describe sudden onset of abdominal pain, cramping abdominal pain and diarrhea, sometimes even while they're eating or immediately after they finish their meal, and there is a lot of wind and flatulence as well. Quite often, and this is something that I look out for, they have other associated symptoms as well, particularly cardiovascular symptoms, where they describe flushing, they describe tachycardias, palpitations. They can sometimes develop flushing of the skin and sweating, etc. as well. And if I see those symptoms, then I think of mast cell activation disorder. And I'm not going to dwell too much on the treatment because it will be covered, but certainly we find that treatment with antihistamines, both type 1, such as cetirizine, fexofenadine, etc., can be helpful, but often in combination with type 2 antihistamines, such as ranitidine, cimetidine, famotidine. But all of these are, in the UK at least, there's a problem with manufacturing, and the type 2 antihistamines are not easily available at the moment. Then there are anti-inflammatory medicines like leukotriene inhibitors, like montelukast. They stabilize the immune cells. And then there are mast cell stabilizers, specifically like sodium chromoglycate and ketotifen, that we can sometimes use in our patients. So, and sometimes we have very, very good responses with this approach to treatment. Eosinophilic esophagitis is a condition where allergy cells called eosinophils accumulate in the esophagus. And on the left side, you have a picture of the esophagus taken during endoscopy, the camera test. And you see that the lining of the esophagus is very nice and smooth. It's got a bit of redness because of the blood vessels, but it really looks quite smooth. And here on the right side, you have a patient with eosinophilic esophagitis. And you see a lot of these arrows and concentric rings that you can actually see all the way around. And this is a esophagus which has become very hard because of infiltration of these eosinophils or allergy cells, and the lining becomes quite abnormal. And this can be diagnosed with a biopsy. Sometimes you have to take multiple biopsies to pick it up because the picture is not as clear as what you can see on the slide. And if the biopsies show a high number of eosinophils, then there can be specific treatment. Eosinophils can sometimes be high with just acid reflux as well, so it's always worthwhile treating acid reflux. But if acid reflux is not the cause, then you can specifically treat for eosinophilic esophagitis. Those with mild symptoms can just be treated with diet alone, and there's a 6-food elimination diet which has been described and has been found to be helpful in clinical trials. So the 6 foods are milk, eggs, nuts, wheat, soy, and seafood, particularly fish and shellfish. And then in those who do not respond to diet or have moderate to severe symptoms, we use steroid inhalers. But the inhalers are not used in a way that you try and inhale the steroid into your lungs, but you just basically dispense the medicine in your mouth and then you swallow it so that the steroid goes into your esophagus. And a 6-week treatment of that can usually resolve symptoms. In some cases, we have to use oral steroids as well. This is usually a treatable condition, and most of the patients get better. The symptoms that this condition produces is pain and chest pain and difficulty with swallowing with the food getting stuck, and these symptoms can be resolved. Coming to the vascular entrapment syndromes, we started seeing these syndromes a couple of years ago, and I'm going to describe one of our patients who educated us a lot with regard to these syndromes. So the most common one is called the superior mesenteric artery syndrome. So this is the aorta, the big artery that comes from the heart down into the tummy, and it has a branched head called the superior mesenteric artery. What you see is that the stomach, excuse me, meets the duodenum, which is the first part of the small bowel, which is a C-shaped structure, and the lower loop of the duodenum goes beneath the superior mesenteric artery. It's above the aorta, so it goes in a gap between the superior mesenteric artery and the aorta. And now, in the normal circumstances, the superior mesenteric artery is held apart from this duodenum by a fat pad here. There's a fat pad which separates the superior mesenteric artery from the duodenum. But if you've had a lot of weight loss, very rapidly particularly, you lose this fat pad, and therefore the superior mesenteric artery collapses down and compresses the duodenum, and that actually causes an obstruction to the flow of contents in the duodenum, and that can produce a lot of pain after eating, can produce nausea, can produce vomiting, and sometimes if you do a stomach emptying test, that will show delayed stomach emptying. So people will get treated for gastroparesis, but this condition will be missed. So in those with significant weight loss, which has occurred quite rapidly, this is a condition to look out for. In the same way that you can get the duodenum trapped, you can also get a situation where underneath the same superior mesenteric artery, the left renal vein, this is the vein which supplies the left kidney, also passes underneath. So if the superior mesenteric artery collapses, it can also trap this left renal vein, and that can also produce quite a lot of pain, and it can compromise the function of the kidney as well. And this is described as the nutcracker syndrome. There is another vascular entrapment syndrome called the May-Thurner syndrome. And this is when the blood vessels come down into the pelvis and you have these iliac arteries, the common iliac artery, and then it branches into left and right. And it has a vein next to it, also called the iliac veins. And this is narrowing of the left iliac vein by pressure from the right iliac artery. So the artery goes over the vein and it compresses that. So this is the branch of the artery, the right one. It compresses this left renal vein over here. And that produces a compromise to the blood flow in the vein. And that can produce quite a lot of symptoms, usually in the lower abdomen. And another condition called the median arcuate ligament syndrome. We have looked for it a lot, not found it very often, perhaps one patient that I've seen, but there are other colleagues who have reported this. So this is a ligament which is normally called, sits just on the aorta as it comes down from the chest cavity into the tummy cavity. And this is the branch called the celiac artery. And as you can see under normal circumstances, this ligament is above the celiac artery. But in some cases, the ligament, the celiac artery can move up, or this ligament has got an abnormal configuration and it actually goes over the celiac artery and it can compress it. And one of the common symptoms is pain after eating. And it can be quite severe pain and is worth looking out for in patients in whom there is no other cause of pain that can be identified, and it's very specific to meal times. Now, moving on to other complications, perforation of the spontaneous perforation of the gut can occur, but perforation can also occur, as I told you, if you have an abdominal wall hernia, that the intestine and quite a large portion has gone through the defect in the muscle. This can sometimes get trapped, and when it gets trapped, the blood vessels can be compromised and the tissue can become necrotic, and that can perforate. There can be hemorrhage as well, bleeding, and that can produce quite a serious complication. And this X-ray basically shows just this is the diaphragm, and underneath the diaphragm in a standing patient, you see air under the diaphragm on both sides. And that is a very good sign of perforation. And that's a surgical emergency and the patient needs immediate surgery. So while in this case, I'm showing you a hernia that has caused the perforation, but in vascular EDS, this can be spontaneous. And I've seen a couple of cases with Tenascin X related EDS where spontaneous perforation has occurred. Abdominal aortic aneurysms have been described as well, that you're familiar with in vascular EDS. So that is a normal abdominal aorta, and here the abdominal aorta has become swollen because the lining is weak and it actually balloons out. And the risk, of course, is that there can be severe catastrophic bleeding. And therefore, vascular EDS patients are often screened for this and they're managed accordingly. So, but of course, these types of aneurysms can occur in other places in the vascular tree as well. Here's a case of abdominal bleeding, and you can actually see that this bleeding can sometimes be visible on the skin. These, whenever you get these big bruises, they can be an indication. This is described as the Cullen sign, and this can be an indication of bleeding into the tummy cavity through one of the blood vessels, which again can sometimes occur spontaneously in patients with vascular EDS. So this again is a significant abdominal emergency, has to be dealt with quickly. I said that we would talk a little bit about Tenascin X deficiency, which this patients with Tenascin X have a phenotype which is very similar to hypermobile EDS, but the only thing is that they don't scar too much, but their skin is very elastic and stretchy, and they're usually very hypermobile, so their Baton scores are between 6 to 9. And they can present, depending on the type of insufficiency they have with Tenascin X, as classical EDS or hypermobile EDS. And there have been some studies from our group which have shown that these patients complain a lot of the symptoms that I've described earlier. So in gray bars, you can see the Tenascin X patient. We've got some control sample from a Swedish cohort because these were Swedish patients. And you can see that symptoms such as reflux abdominal pain, indigestion, diarrhea, and GSRS is a questionnaire that we use, gastrointestinal symptom rating scale, and the total score on that is much higher in the Tenasci-Nex patients. As I've said, I've seen a couple of patients with Tenasci-Nex deficiency who have had a spontaneous perforation of the bowel as well. And just really to summarize about vascular EDS, as I've already mentioned, organ perforation or bleeding can occur. There have been some familial cases of sigmoid perforation as well in vascular EDS. There is an increased risk of colonic perforation during colonoscopy in vascular EDS, but not in hypermobile EDS or hypermobile spectrum disorder. We've recently done a study on that and didn't find any increase in risk to colonoscopy in hypermobile EDS and hypermobile spectrum disorder. Occult and overt small bowel perforation has been described in vascular EDS. Esophageal perforation has been described. Congenital diaphragmatic hernias have been described, and spontaneous bleeding into the spleen, liver, and various perforation and thrombosis following surgery has also. So surgery also carries a risk in these patients that needs to be. So I think that's it. Hope you enjoyed that presentation, and I just need to thank various colleagues who over the years have been very helpful and have worked alongside us, and also particularly thankful to Lara for her support that she's provided over the years. Thank you very much.